unlikely in this first half, but it'll probably come in the second half, I would think, even though it's what we typically follow bones up with. So now I've begun recording, and I did not get the opportunity. We had left it here, and I don't want to spend an inordinately long amount of time on skin. Have you started skin yet in lecture? Okay. I'm going to give you the lab abbreviated skin version. And when we left, this was the last thing we talked about, because I usually check it, and then I'll do the full introductory bones presentation. We had talked about the cells of the epidermis, and really the most memorable part, let's hope this all works, of skin is that it's in layers. You remember this is called stratified squamous. The reason it says squamous is the outermost layer, the part that's out here. Basically, the cells, not only are they flattened, they're dead, as you will see it. So you have classically 5 layers. A base layer where they grow from, a layer where they enlarge and reproduce, and as they move farther away from their blood supply, no other way to say it, they die. And that's what makes our skin different, let's say, than the lining in our mouth, where the blood supply is a lot more generous and the cells don't die. So what you're going to see here is the change to this, what they call the stratum granulosum. Understand that when we look at things under a microscopic slide, and I know Dr. Robbins likes to do these in lab, I'm not in love with doing the microscope at this stage of the game in the lab. When I used to do the micro labs, I spent a lot of time. That's where I really familiarized students with it. But nevertheless, that's everybody has their own preference. You're going to see that some of these changes probably have more to do with staining and preserving the sections of skin that they look at. When they take a piece of skin out and put it and slice it and preserve it and add dyes to it, it creates, sometimes the image is more created than actual. And you'll see that something that we call the stratum lucidum, the so-called extra layer that we see in palms and soles in your lower back, is probably more of an artifact in the sense as those skin cells are dying, they don't pick up the stain. It looks like there's nothing there. And lucid means clear, so it's a clear layer. You'll see this, easily find those slides anywhere. Well, the basal is the base layer. It's not flat, because what you saw with skin, it's a series of hills and valleys, ridges and pegs. But it's all along those hills and valleys. Typically, the cells are cuboidal or columnar, very firmly attached, very, very active mitotically. On average, the skin that sheds off of you every day, the thousands and thousands of cells, are about 30 days old. There's variation. Some could be as little as a couple of weeks. One of the things we think about with psoriasis that it's skin that's really being reproduced so rapidly, and it hurts when they shed because the cells are not completely dead. You want to think of it that way. And there's other people on the other side of the spectrum where their skin reproduces so slowly, it gets very thick, almost leather-like. It's got a fancy word that you'll hear about down the road called lichenification, which means leather-like. So what effectively happened, these cells are being pushed farther and farther away from their blood supply. It's kind of like you're building a wall, but you're not putting new bricks on top of the wall. It's like you're lifting up the wall and putting another layer of bricks underneath it. It should be hard, to say the least. Okay, so it's a germinative or growth layer. About 75 to 90% of the keratinocytes, the main cell, 10 to 25% of the melanocytes, the pigment cells. As the cells begin in the next layer, and this is one of those, like, it may have to do more with the stain than anything else. It's like they're being pulled apart. So what we often see is these cells are held onto each other by a series of those junction points in desmosomes. They're very strong. Now, I have a wonderful tool here, and I spare no expense. Many of you may know what this is from the dog. I don't leave home without it myself, because you never can tell. For the dog, not for me. So the cells, what happens is they grow away, they're still attached, and they begin to form almost like they go from being a typical, let's say, rectangular form, and you're going to see these sort of spiny points come together. And we think that that may very well have to do with the staining and preservation. And it really isn't necessary. And they call it the stratum spinosum or spiny layer or prickly layer. And yeah, I mean, skin's very sturdy. And what happens now, the melanosomes are making pigment, and the pigment is being sucked up. So this would be, so if this was a green pigmented person, that the pigment would be coming from green melanocytes, but there is no such thing. I don't want to leave this here. Remind me. It's the dog. And now, this is the big change. The granular layer. The cells start to flatten. The nucleus starts to flatten. That tells you the cell's dying. We begin to see little granules, fancy name, keratohyalin granules. They're going to make the keratin, which is the structural protein that really makes skin. Fats form. I mean, this leads to the waterproof nature. And once you're above this layer, the cells die. And then all you have is basically a bag with keratin that's very, very strong, very, very sturdy, waterproof, resistant to tearing and pulling. And generally you have to, it's not easy to cut into skin other than with a very sharp object or, fall down on rough ground, skin and knee, something like this. The lucidum, again, thick skin, we think they call it a translucent band. I don't know that that's necessarily true. Again, I think that's more likely just an area that didn't stain as the cells transition from dying to dead. And then finally, we see this stack of horny layer. Cornification is a rough outer area, very, very thick. They say 20 to 30 rows. Some authors will say 30 to 40 rows, and they're all very protective. And so effectively, it's a fancy word that you should become familiar with called apoptosis. Programmed cell death. We do a lot of that. Okay, a lot of the things that in us are growing when a child is growing in the uterus, transitioning from embryo to fetal and to adult. There's a lot of cells that are there that begin to die and change. So it's not, and as you can see, we shed tons of these. You don't necessarily see them. Elderly folks, you'll see them on because they'll get almost like a white powder. It almost looks like a dandruff. You see elderly skin. If you're like me, and I spend a lot of, I'd say 2/3 of my practice was elderly folks. So this is kind of what it looks like schematically here, micrographically here. Now there's a real, and this is that little sort of hill, and that's all the blood supply. That's what and they summarize all this stuff. Underlying it are two layers. One is called the papilla are these hills and valleys, loose connective tissue, which is always under epidermis. That's where the blood supply is, tiny nerve endings. And then the real thing that gives your skin its strength is the deeper or reticular dermis. That's the part of your skin that effectively is the leather-like area. In an animal, that's what they make leather hide from. Those hides is from the deep dermis. So this is the papillary layer, these hills and valleys in green. That's epidermis. This is the dead skin cells, this mountain, 20, 30, 40 layers thick of dead cells. You don't see any nuclei. And now as you get deeper, it's about 20% papillary and about 80% deep dermis, which is, if you want to characterize the tissue, is dense, irregular. So the fibers are abundant, not a lot of blood supply. It's very, very tough, but they're going in all different directions, not well organized at all. And so that's what you have. And then there's a variety of other structures that are there. For instance, the pattern of these hills and valleys give rise to what you and I call fingerprints. They're unique to each one of us, okay? And effectively, tiny bits of perspiration and oils come out of little pores. And so when you touch a surface, depending on the surface, you may or may not leave a fingerprint. And obviously, there are a lot of importance forensically or legally for identification. Plus, you can grip with them, they add to touch, and that's what they are, these friction ridges. So if you wonder where they came from, it's sort of a unique pattern of hills and valleys that we all have that are there. I don't know enough about them from a standpoint of crime solving and problems like that. And a lot of folks do. I don't. Okay. The deeper dermis area, much thicker, lots of elasticity, lots of collagen fibers. Okay. Lots of blood supply, and the blood supply is not within it, but on either side of it would be a better way to describe it. That's there. And interestingly enough, when it forms lines that you can't see, we call them lines of relaxed skin tension. And it's what surgeons use to make incisions. When I would operate, for instance, it's almost like you can pinch your skin this way. And so if you pinch it one way, you can't see the lines like this. If I pinch it this way, I can. So you would make a skin incision in this skin along those lines where they sort of pucker up a little bit. You can see it on yourself. The idea is it's less likely to leave a visible scar. You cut in there and put stitches, you're going to be scarred. The whole idea of plastic surgery and good surgical techniques is to not leave obvious scars. And interestingly enough, in plastic approaches, you can take, maybe someone got a bad cut or a dog bite or a cat, that type of thing. And even if there's a scar, there's ways you can change the angle of it cosmetically with more advanced plastic surgery techniques. It's really interesting. My granddaughter, who's a little older than you are now, my eldest, at 22, and she was like 3, her other grandpa's dog nailed her on Christmas Day. Okay, and we're just fortunate that it caught it in a skin crease, so she never had to do anything with it. I mean, that kind of scary. My daughter's calling me, oh my God, we were going to send her to Children's, and there's a 12 to 24-hour rate for stitches. It's like there's an epidemic on Christmas. Bad things happen. So it's really important. So this is a good map of it. So when we do, a lot of times when you operate, you make an incision so you can see it. If you're going to operate on somebody's belly, you're going to ignore the way the lines go and go right down the midline because you're looking for exposure. If you're going to put in an artificial knee, you would go just along because you're looking to see what's there. Or there's a big tumor, you want to expose it. But if you're doing it more of an elective procedure, you might make the incision this way and then that way, and then it's almost like a zigzag, like this and then like that, trying to make sure that cosmetically it's less apparent. And lastly, you get, because if this happens on these areas, hands, wrists, and marks on your palm, for instance, are most obvious. So you may think it's whatever you're feeling about somebody reading a palm, whether it's just doing it something for fun or people haven't take it very seriously, you actually can tell because people who use their hands a lot are going to develop certain kinds of creases, and people will see that they're skilled. There's a lot of that interesting stuff. A lot of things that, when you think about things that are magic tricks or these kinds of tricks, there's a lot of science that goes into them. And you can have some fun doing that. On at least 2 occasions, if you're familiar with who Penn and Teller are magicians, and what they do in their act is they kind of show you how they do the trick. So you get an idea of how those tricks are done. So, I mean, they don't give away the story completely, but it's very interesting. They show you can go down there and look at the stuff, and in a theater that's dedicated for them in one of the hotels in Vegas. So whenever you get a chance to do that, go ahead and do it. It'll be fun. So, and these are things like stretch marks. Blisters are interesting. They come from side to side movement. And what they do is they separate the epidermis from the dermis. That area is filled with fluid. And it can happen normally from side to side, pulling and tugging. It can happen from other things, swelling within. So if somebody breaks a leg, it'll swell up so much, it'll separate the skin layers. And certainly we'll see it. We'll talk a little bit about burns before we do too much. Those are stretch marks. The melanin, without going into, is a pigment. There's different kinds of melanin. I'm not going to spend a lot of times on hair and nails. The melanin there is different. I mean, the bigger part of the keratin is different. And what accounts for pigmentation or the lack of it has to do with certain kinds of pigment. Melanin is the principal pigment. We also get some pigmentation from hemoglobin. So if you look at your fingers and you squeeze them, it's called blanching. Many of you in nursing will do this to assess circulation. You'll squeeze it, It'll be white, and it should pink up right away for a healthy person. Called filling time. If it's very delayed, immediately you say to yourself, whoa, something's going on. So we look at filling time a lot. Or if you look at the nail, same thing. You can squeeze it, it's white, then it pinks up right away. That's from the hemoglobin. Now, some folks, there's carotene, which is vitamin A, used more in your eyes for seeing, but well, sometimes it doesn't necessarily impart a yellowish skin. I think we mistakenly attribute that with folks of Asian descent. It's more melanin there. It's sort of a blend, genetically speaking. And when we see yellowing in the fingernails or in the eyes, the whites of the eyes, that's very often jaundice. That has to do with the accumulation of bilirubin, which is a breakdown product of your blood as it's being recycled that the body has to get rid of. And if there's a problem with the liver or the gallbladder, a blockage someplace, it backs up into the system. So there's lots of different things that are part of it. The big, it's on you. If excessive exposure to the skin is a problem, melanin protects your DNA. A lot of medicines and over-the-counter products can cause what's called photosensitivity. Some people will take an antibiotic, they can't even go out in the sun. It's like they feel their skin's burning up. It's not, but they feel that way. My mom had that to a certain extent. Okay, and so everybody's a little bit different. Some people just love to be out in the sun. And the other thing to be careful of, for those of you who are interested in use tanning beds, understand what the restrictions are and do some research about it. Okay. I've been trying to tell my daughter that for the last, 20 years. Still hasn't worked. Because it's bathing suit season. Year round for her. Go figure. Hey, what are you doing? I can't talk, Dad. I'm tanning. Can you do that? So here they are, carotene, probably a little bit more palms and soles, I think. It's used a lot for visual pigments, which you'll get to next term. The hemoglobin I just showed you. Looking at skin color, whether someone's pale or dusky appearance or yellowish, like I said, when someone's inflamed, they get erythema. That means redness and usually some heat's associated because you have increased dilated blood vessels and more so. All those are clues. You always put the picture together. It's all little bits of information, and the longer you do this, it becomes much easier to process. And black and blue marks, they're broken blood vessels. What does blood do? Our body resorbs it, processes the hemoglobin, and it changes colors. We've all had a bruise. We've all watched it change colors. Sometimes they're more distinctive than others. Some people bruise more easily than others. I'm one of those. That's a hereditary thing. Okay, my mom had that as well. It's like that, and you can, and a lot of these, and some of them we associate with odd things, And again, they're all little clues that are there. Hair and nail are very similar. We call them skin appendages. The keratin is a little harder and drier. We have hair almost everywhere. Wherever you have hair, you always have oil glands. It varies with how oily or not oily your hair is. I think that's more genetic. We can approach that there's so many dermatological products that you can get without a prescription or with a prescription. It's improved dramatically since when I started in the business I was writing prescriptions in 1977. I haven't written one in 25 years because I haven't been in practice, but we knew a lot about it then. And the skin lines have really improved tremendously. The amount of skincare products, quality products that are there. So, and you can see what hair generally does. The follicle, the hair that protrudes out is dead, just like the outer portion of your skin or the edge of your nail. Where it is within its follicle is living. Different kind of keratin. So the root within the scalp, if you know someone who's undergoing hair transplants, they basically will take hair, let's say from a hairy area with the follicle and basically transfer it toward them, let's say, the ear. I've never had the inclination to do that. It's all right. I'm good with it. My dad and my uncle had hair pieces. drawn to that. I mean, I am what I am. So, I mean, just to be rude, my wife says, you know, that forehead's getting farther back. Thank you, dear. Love you too. That's why I work here. I don't get this abuse here. Okay, and you're going to learn these terms too: medulla and cortex. Medulla is the interior, cortex is the exterior. Your first time you really learn about it is over there with bones. And the cuticle on a nail is that little bit of skin. The hair, it's like a waxy outer layer. And again, genetically, some of us have more than others, just depending on what it's like. Okay, there's different kinds of melanin and reddish hair, and again, it's mostly hereditarily oriented. When you have somebody with gray hair or white hair, typically air bubbles are in there, and it happens to people at different times. My wife's hair turned prematurely white very early, comparatively, and then she colored it for a while blonde, and now she just kind of leaves it the way it is, and I think it's a very flattering feature. Because everybody goes, oh, your hair's so nice and all that stuff.
But what about like there's some things like when they patch of white hair.
And then yeah, it's probably more genetic than anything else. It's pigments in that it doesn't necessarily follow a pattern. Like folks of color, particularly in a burn, will depigment. And then there's a disease called vitiligo or leukoderma, where they, without anything, without a burn or trauma, they'll depigment. And it's much more common, let's say, to see albinism in folks of color than not, for whatever reason. And that has to do with a genetic defect in the making of the pigment, which comes from a protein, which comes from amino acid called tyrosine. So when you see that, every so often you'll see a tuft of things like that. That will happen. I agree. It's very interesting. And the curious would be if it was familial in nature. In other words, other folks had it. It's weird. When we talk about hair and baldness and things like that, it's most times what's called sex-linked. So it's inherited from the mom, and generally it's covered up because effectively in women, they'll have another X chromosome that will cover it up so it doesn't demonstrate so, although it may. Versus in men, they do not have a second X chromosome unless it's some genetically out of the ordinary picture. And at that point, that's why we typically see male pattern baldness, and there's other things that contribute to it as well. And it's funny, I don't know where it comes from. My maternal grandfather had a full head of hair when he died, and like I said, on my dad's side, he had not a lot of hair. Go figure. So sometimes I think I got the worst of both worlds. All the men on my dad's side, with my dad being the shortest at 6 feet. I mean, I'd do anything to get another 3 or 4 inches in height. Just wasn't going to happen. One male cousin, he has a twin brother and sister, both deceased now. Both of their sons are like 6'3", 6'4". I'm lucky to get 5'8.5". I'm vertically challenged. See, I look at those height weight charts. 5'8.5", big frame, 170. At 215, I should be 6'4". So it's not overweight, it's vertically challenged, not horizontally enhanced. Just saying. I'll keep saying that. So as I tell my wife, get in shape, rounds a shape. I give up. So, and basically the hair is wrapped in connective tissue that's kind of like dermis, derived from dermis, and you can look through these. Where it grows from is called the matrix. The nail, it's the same thing. That white area we call the lunule on your finger and toenails it looks like a moon. That's where they get the term lunular area. Underneath it, that's the matrix. So hair and nail both grow from that area. And yet there's a little muscle that makes our hair stand on end when we're excited or cold or whatever. That's there. And so this is the connective tissue that's growing, and this is the blood supply. pigments coming from here. You have waxy type cells in the interior, creating some degree of cuticle area. Within, there's also some waxy areas on the exterior. And I mean, so this is this is schematic. This is what it looks like actuality. So you can see it's growing, and again, as it gets farther away from this follicle with its elaborate blood supply, the hairs begin to effectively die and change. Those hairs on us that grow are called terminal hairs. In women and in children, they have something called vellus hair, which doesn't have a lot of pigment, very, very fine. But not everybody has that. Okay. And then there's a thing called lanugo, and a lot of times that's like a layer of hair and tissue in babies that sheds. That we see in infants, and sometimes they'll shed this outer layer, which is somewhat unique in that area. And then in puberty, we develop the secondary axillary and pubic area hairs. Lots of things affected. It grows. We do lose hair, and that's not very long. I mean, that would be an inch on average. Let's say that's about 1/10 of an inch in so maybe 10 weeks, 2.5 months. So everybody's a little bit different. Okay, and your hair gets different. Wavy, straight hair is not terribly normal. Curly hair, those are odd. A certain degree of wave to the hair is more normal than that. And all those types of things. So my daughter is one of those who, likes her hair real super straight, and is always using those whatever, like flat iron type deals. So all of these things, they're hormonal abnormalities, whether they're androgens, which are male sex hormones, which the adrenal glands in women produce, can cause something called hirsutism, being extra. Here's funny, and a lot of times we see it when people are under emotional stress, trauma, life events. They'll lose patchy areas. It's called alopecia areata, was the original term. We saw a lot of that when I was a resident. We went on dermatology rounds, and we saw it probably in younger men and women, more so than in older folks. And then there's male pattern baldness, which may or may not have to relate to a response with regard to testosterone. So, and that's really where it is. Now they're calling it this telogen effluvium. That was that alopecia areata. And you can see there's lots of things that can play a role. Chemotherapy, well known for causing that, but there's a lot of things that do. So there's a lot of factors. Dermatologists have a lot of information about that. Some of them are very cosmetically oriented. A fellow we knew pretty well, wonderful practice over at North Hills Pacific, probably maybe a year or two older than I was, maybe retired. I don't know, but they did a lot of treatments for baldness and other things, a lot of cosmetically oriented stuff. Nails, very similar. The part that protrudes that we cut is the free edge. It sits almost directly on hardened skin called a nail bed. If you lost a nail because you banged it with a hammer or stubbed your toe, that nail bed will toughen and harden. And then as the nail grows over it, it will start to soften again. But that's why it's so tender. It's filled with nerve endings and blood vessels. Oh, they hurt. Anybody stubbed their toe knows that. How bad that is. And again, from the matrix. And the folds and the cuticle, and there's not a whole lot to say about it. This says it pretty well. And again, your ability to grow nails is, again, hereditary. Those kinds of things. How much people spend so much. My daughter, and understand my kids have no genetic relationship. They're all adopted children from not biological siblings. So my nails are like, never break. My daughter, when she was 15, her first paycheck from McDonald's, what did she do with it? Nails. That's it in a nutshell. What are you doing with that? I'm getting my nails done. It's only $25 or $30. Really? That's my daughter in a nutshell. I have a picture. It's okay. So and we look at that. Your nails are a mirror, just like your skin is to systemic disease. Yellow areas, thick nails, respiratory problems, the nails start to club. Fungal infections are very common as folks get older. Iron and vitamin deficiencies weaken nails. A Bose line's fascinating. If you're fortunate enough to follow a patient, if you're in a field like that, let's say they came into the hospital with a heart attack, and you saw them 6 months later, you'll see a line about halfway up their fingernail going across, called a Bose line. It usually indicates some type of significant life event. And so, whether it's diabetes or heart attack, and I've seen those on more than one occasion. Nails are really very, very interesting. This is typically vitamin deficiency, some type of nutritional deficiency.
What about,
It from an injury or it just appear darker? You have to think something off with circulation, would be my first guess. A lot of times when we see purplish color, it tends to point more to respiratory problems. Might be the way to do that. And look, everybody, it's so hard. I mean, you're all young. Hopefully, you're all healthy. I do yourself a favor. Don't smoke. It's the biggest single problem. That a lot less smokers today. Take it from somebody like I told. I'm sure I told you. 40 years, 2 packs a day. Nobody smoked more than I did. If I hadn't stopped, you'd have someone else giving you this talk. Different kinds of glands. Glands differ based on what they make. Every time I move, my back goes like this. Okay. So there's 3 kind of types of glands. Yeah. Thank you. Something I said. I had to pick the one that doesn't. Oh, I didn't bring it with me. I'll show you. Sorry. So, typical when you perspire, it's just fluid water with some electrolytes. They're called eccrine or merocrine glands. Here, sebaceous glands are very oily. They reflect the whole cell. And in between them are apocrine glands. And if you remember when we talked about it, you have the base and the apex. The apex, the apocrine glands, break off a little tip of the cell, so it has a little bit more oil, but not quite as much as a sebaceous gland for your hair. That's the difference. Some people erroneously think they're not there. We think that during milk production with lactation, that's probably apocrine. Caruminous glands in your ear, probably apocrine. Glands, secondary sex glands, axillary or groin, probably apocrine. And you'll see those. So the eccrine, by far and the most typical sweat gland. Thermoregulation, triggered sympathetic, which you'll learn about this term, mostly water with some odds and ends. Okay? And they will either kind of look like that, kind of twirled around, coiled. Okay? The apocrine gland, it's a little thicker. And sometimes, again, it's less hygiene than heredity. Okay? Some people are more prone to body odor than others. You have to do what you have to do with it, whether you use some type of deodorant or some people will just try to use something that will block the degree of perspiration. Not everybody can tolerate that. And again, the ones that the anogenital and axillary glands are there. And here are the ones that are modified, earwax, mammary glands, and everywhere there's a hair follicle, there's one of these. And understand, sweat pores and hair follicles go through the skin. That's the good news. The bad news is they're entryways for infection. So when you know somebody, we all do, with acne and problems like that, and you folks are in that sort of that age area where that is, that's basically a sebaceous gland that gets blocked, and some people are more prone to infection than others. And sometimes it's very severe, sometimes you're fortunate if you aren't affected by that. So those are called holocrine, or the whole gland. I'll show it to you in a little bit. And I'll see if we can, there's the acne, that's cradle cap. Seborrhea or seborrheic dermatitis is something you can see in infants. And if you look at me and you see darkened areas that are dry, as people get older with their skin, typically that's seborrheic dermatitis or a seborrheic area. It's not something that people go crazy because they think anything that looks different is skin cancer, and probably isn't. Your family doctor usually gets a good head on that, right? And it's a multiple barrier, and you can read this as well as I can read it to you. It's a chemical barrier because of acidity and salt, a physical barrier because it's tough, it's waterproof. Things can get through it. We use patches on skin for a variety of things. Everything from nicotine patches. Why? Because it isn't active orally. It's broken apart by stomach acid. So painkillers, seasickness things, they've been around forever. Nitroglycerin, which is sometimes used to quickly lower blood pressure, deal with heart problems. When you have somebody with poison ivy, it's a resin that's slowly absorbed. The good thing about skin is you can predict how rapidly stuff will absorb. So you know exactly what the dose is that will be absorbed. That's why it's useful. Biologically, it's got cells that fight infection. Your skin is entirely covered by microorganisms. Every square nanometer of your skin is covered with bacteria and fungi. You may not want to hear that. It's true, but they're your friends because they're the good guys that keep the bad guys away. And I think that's about it for that. Perspiration, we lose about a half a liter normally. When we feel it, when we're actually perspiring, it's called sensible perspiration. Not a whole lot. Blood, excretion. Last two topics, and we're done with this, and we'll start bones. Okay, last two topic. Number one, burns. Okay, burns are thermal injuries. It doesn't have to be hot to be a burn. It can be cold. Frostbite is a kind of a burn. Okay, exposure to cold for a long period of time. Even frostbite generally is a combination of moisture and cold, but actual pure cold can be just as problematic. They cause the skin to die. Blood vessels clamp down, whether it's cold, and the heat, they just damage the cells directly. So thermal injury, they can be electrical, they can be chemical, they can be radiation, whatever. Okay. And so and the biggest single problem with burns is it damages the barrier. And what that does is it causes two things to occur. One, you begin to lose large amounts of fluid and electrolytes, and the other, burnt skin is comfort food to certain bacteria. You'll learn about it when you take micro. Many of you will take that next term. The bacteria you're going to work with in the lab is in the soil everywhere. It's called Pseudomonas aeruginosa, by far and away the most common thing for burns. Very hard to treat. So when it comes to skin cancer, it's the most common, statistically, the most common kind of cancer. On average, 1 out of 5 of us is going to have some type of skin cancer. The good news is 99% of the time, it just has to be removed. You don't require any aftercare, radiation, chemotherapy, stuff that would make you sick. Exposure to ultraviolet, most common idea. There's lots of things that they have today that can help. This is the most common one. It's called a basal cell carcinoma. It affects those germinative cells in the stratum basale. How do you determine which one it is? By biopsy. Take a section out, look under the microscope, see where the changes are. Squamous cells are in that prickly layer, the one where they start to get the dog bag out and you can see again. Just don't ask me. Okay? Those require radiation or chemotherapy. You have to be a little bit more. Basal is just removal. Melanoma, don't want to have. That's a pigment cell cancer. It has a terrible prognosis. It's based on how deep it is. Is it confined to the epidermis? Does it go into the dermis, deep dermis, subcutaneous, or fatty layer? The deeper it goes, the worse it is. And when we talk about cancer, we talk about survival rates. What's the 5-year or 2-year or 10-year survival rate? Not good. Not a diagnosis you want to have. Okay? Basal cell, very common. Stratum basal, very slowly invasive, typically excision. You always see this one because it's usually exposed areas, nose, scalp. So it just looks funny. Squamous cell can spread. Stratum spinosum, again, scalp, lips, hands, exposed area. So, and again, you wouldn't know the difference until you took a sample. The melanomas look awful. And they've been studied for a long time. When you have a mole, which is an accumulation of pigment, what you look for, or a loved one looks for, if you go to a doctor, they'll take pictures with like a ruler, something for context, and you'll measure it. Is it getting larger? Is it changing color? Is it growing irregularly? Are there little bumps forming in it? The only thing that isn't abnormal if hair comes through it, because hair growth is normal. Okay, so is it asymmetrical? Does it not match? Does it not look uniform? Is it irregular? Is it indented? Are the colors changing or becoming more vivid? How sizable it is? All those are things that you look for with regard to it. And there's that picture again. Burns are just that. They break down proteins. Doesn't matter. Proteins denature, change, heat or cold. Temperature is the most significant factor. Dehydration and electrolyte imbalance, loose fluid, you go into shock. This is the criteria when you see in the paper or listen to the news and say, oh, it's a terrible accident, and one of the individuals had burns over 30% of their body. Well, the doctor doesn't go, it's about 30. Called the rule of nines. This, and I'll show it to you. It has to do with breaking effectively. Different areas have different amounts, and you estimate. We use this for criteria to refer to a burn center. A burn center, and there are two, I believe, still in Pittsburgh. Mercy and West Penn Hospital over in Bloomfield are the two major burn centers. In order, and the criteria is very fixed. It's a little looser for kids. Okay, kids are much more likely to be accepted. If you have burns on your hands or feet, it doesn't matter how limited they are. That's a burn center referral. Facial burns, genitalia burns, immediate referral. After that, we start talking about percentages. And they don't always have to be third-degree burns, because if you have enough second-degree burns, you're losing so much fluid, and it's such a risk of infection that it could be. And so what we do is we divide the body into 11 segments of 9, and the anogenital area accounts for 1%. So, and there's a skin thingy here. You see it all. This is what we're looking at here, normal skin, and then the burning. So when it's confined, the first degree burn, it's just a dermal, it's just the epidermal area. In second degree, we get into the superficial dermis. And the distinction, you will have this first of all. Have sunburn of a few days, and so on. Or snow starting to blister, okay, same here. Third degree, deep dermis. Because of that, damaging nerves, blood vessel, it's bound down, it hurts intensely, and then it goes away because the nerves are gone. And inevitably, it requires skin grafting, dysfunctional damage. So there's a lot to it. Now, I've seen these. I was a resident in Philadelphia. There was a fire at, I don't know if the hospital's still there because they combined them. Our hospital was about on 8th and Girard. This was on about 3 or 4 city blocks over. And the fire was so bad that they had to bring patients to all the other hospitals. And we had people in the sun porches and rooms. Just a tragedy. We had burns at a flop house. A flop house, for those that don't know, we were a lot of homeless men, particularly. And for 50 cents a night, they could get a bed and a warm breakfast from some foundation. And it caught fire. Are you ready? Christmas night. We were swamped with a disaster drill. You'll learn about these with 50 of these guys, and their clothes were burnt through. 2 of them died in the ER, 2 of them died in intensive care. That was the night I learned to start IVs, because everybody who came in, we had to run 2 IV lines to get fluids into them. And we had to do, at those times, they didn't have those neat little pulse ox things you could put on your finger. We had to do what's called arterial blood gases. So you'd stick them in the radial artery and get the blood that way to figure out how their oxygen saturation before the technology. And by that happened like at 6 o'clock at night. By midnight, the Red Cross was there with clothes for all of them. That's your one. Because none of the clothes, they were cutting off clothes. Clothes were buried into the skin. Wild. And it's not just me. Anybody who's a resident or a nurse in an emergency room environment, you all have these stories. We all have them. Okay. Give you an idea. So blisters versus the full, I'll show you all these. Fingertips, now you see the blistering. Partial thickness, first and second, is the part. Full thickness means you're into the deep dermis. Fat begins to basically melt, if you want to think of it that way. Tremendous loss of function. So 25% of the body, based on the criteria you're going to see, will be critical, which means burn center. 10% third degree, don't need a lot. Face, hands, feet, as I said, genitalia. We remove the dead skin, topical agents, tons of stuff for pain, temporary coverings, and here's the criteria. So your head, facially, most of the skin, it's 4.5, but probably more, maybe 6 and 3%. Upper extremities, 4.5, including the hands, 4.5 on the back, flexor and extensor surfaces, each one. So that's 3 nines. Torso's the most. 9 upper torso, roughly the diaphragm. 9 lower torso, anterior. 9 and 9 posterior. So that's 36% there. 999 is another 27, 63. The 1% here, anogenital. And then the lower extremities, like 4.5 in the thigh anterior, 4.5 in the leg. That's 9, including the foot, 4.5 in the back of each. And so you end up with 9 in the front here, 4.5, 4.5, 4.5, 4.5 in the back. So 18 there, 18. That's how you get your rule of nines. It's been used forever. Voila. All you need to know about skin, we're afraid to ask. That's the fun part is now bones. I brought out some bones just to give you an idea. And it's fortunately for you, folks, at this level, I just want you to know the names of the bones and some of the features. So there's a couple of PowerPoints that play with this. One is 6A, and that gives you an idea of what these features are about. And the other one is really where all these bones and features are. That's 7A, B, and C. So when you see those, either week 1 or week 2, that's where you find them. So here's 6. Now in lecture, they'll give you the idea of what it is and what it does. Understand, other than our skull bones and our clavicles, our collarbones, all the bones come from a shell of cartilage. So when a baby's starting to form in utero, even in the embryonic stage, that cartilaginous frame is there. It gradually becomes bone. Some of it's already bone at birth or before. And so that's one of the things. And then as time goes on, by the time you are, quote, bone mature, for most of us, for women between 15 and 18, for men, probably 18 to 21. And that's when it's basically all bone with a few little exceptions. So without going crazy and going over cartilage again, this is what to show you. So the cartilage that bone comes from is called hyaline cartilage. Hyaline cartilage is the cartilage that is in your respiratory system, like for your nose, trachea, larynx, Adam's apple, into the lungs, the bronchial arrangement. Those are all hyaline cartilage. We have a limited amount of cartilage in the ear, is elastic. the epiglottis that covers you when you swallow, so food doesn't go into your windpipe, so to speak, and everything else is. And then the fibrous cartilage is the discs, which I'll show you when we get to the intervertebral discs and in the knee, etc. So you see these illustrations all over that are there. It either grows long, that's called interstitial, wider, that's called appositional. That's true for cartilage and for bone. Okay, we're not going to get into all the ins and outs. That's more about lecture, about how bone grows, where it grows. The short course. Cartilage does not have any blood supply. It gets all its blood indirectly. Bone has a magnificent blood supply. Typically, when cartilage is invaded by blood, that's the trigger that starts the transition. So it does all these things, and this again is more of a lecture thing. Blood formation, a limited amount of fat storage, okay, that's part of it. Support, protection, muscles attached to it. Big player here, mineral bank for calcium and phosphorus, etc. Bones are divided, and this is really important. The way to remember them is based on how they're aligned. You have your core, they're called axial, the long axis of your body. Head, neck, chest, backbone, skull, vertebral column, ribcage. That's the axial skeleton. Everything else is appendicular. Arms and legs, hands and feet, and by definition, the connectors. So your shoulder assembly and your hip assembly are considered part of the appendages. And you're going to see that's going to relate to muscles because we categorize them, whether they're muscles from the axial to the appendicular or just the appendicular. You're going to see the same categorization with the central nervous system, the brain and spinal cord, axial, the peripheral nervous system, more appendicular. That's the way to learn this stuff, I think, is to try to compartmentalize it. You saw that illustration before. 4 kinds of shape. Long bones, short bones, flat bones, and irregular bones. It has nothing to do with size. The tip of your pinky, a long bone, or distal family. Tip of your baby toe, a heel. Not very long. It's certainly not as long as the femur, but they're both long bones. They're longer and they're wide. When we study bone, particularly in lecture, we look for that because it really gives us an idea because they have a very thick shell called the cortex, here those terms again, and they have an inside that's kind of spongy, kind of a unique pattern based on usage called cancellous or spongy bone. So the outside you have a cortical bone, it's very, very hard, okay? And the inside you have cancellous or spongy. And then even within that, the long bones you have a marrow pattern. When you're growing, it's got red bone marrow that has a lot of blood formation associated with it. As adults, a lot of the long bones, the red bone marrow is replaced by fatty tissue as yellow bone marrow, and in emergencies, it's naturally good. In adults, things like this area, the head and neck of the femur and the humerus, shoulder and hip assembly, they still have a lot of red bone marrow. Bone marrow in your sternum, things like that. So that's a long bone. Longer than they are wide. Nearly all the bones of the limb, with the exception of the kneecap, here, is a short bone. Short bones are cubic. They're nearly all in the wrist and the ankle. They're interesting. They don't have a lot of hard bone on the outside. They're nearly all spongy bone on the inside. They have a lot of cartilage because, I mean, look at all these bones in your ankle. It's really beat up. This is real skeleton. Okay, all these little bones are covered in cartilage. They're all involved in joints. The whole thing you do with wrist and your ankles comes removed most of you, right? Because of that, when they're injured, hard to heal, all that part of it. Because when they break, the blood gets in there, and say blood is very destructive inside of the joint. So there's other bones. A sesamoid bone forms within a tendon. The classic is the knee. There's other sesamoid bones. So they vary in size and number. To have a fair amount of extra little bones, that doesn't count in that 206. Okay, it's not unusual to have them. It's not unusual not to have them. They don't really use them a whole lot. Okay. Some people have extra, but it's not a big deal for you. They play a role functionally in sport. Some of them. So you have long and short bones. So short bones basically wrists and ankles cover a multitude of sins. Long bones. Flat bones are odd. Flat bones, the bones of your skull. Even though I got these all marked up and they're not all from the same one, sorry. Eventually I'll think about putting them together in some way or somebody else more talented. But they kind of sit like this. Okay, so these flat bones are curved. We call them flat, but they're curved. They typically don't form directly from cartilage. They form inside. Why they form in that? All of a sudden, in tissue, all of a sudden, bone structure can be. And it's got a very thin outer shell, and the skull a little more sturdy, and a lot of spongy bone. It's like a big sandwich. The hard bone on the outside, and spongy bone on the inside. They're called flat bones. Your ribs are like that. So maybe a rib is a better way to look at it. Keep one out of this one. But I know I have to the other. You look good. No one likes a wise. This is collarbone, clavicle. Probably that's why it was long bone. So you have ones that are long, those are short, another rib is short, probably right up here. Flat. So you have flat in the area, tip of the curve a little bit, with a fair amount of narrow. And then they're all part of that. So those are like that. There's some oddball bones that should really be odd. The regular bones are, they don't really conform to any of those other shapes. And sometimes they have groups. So here's an example of one that's kind of common. And I know it's beat up. This is your hip bone. So it's somewhat flat here, irregularly shaped, giant socket for your hip. That's all an irregular bone. The sacrum is probably more like flat bone. Coccyx, same way. But the ones that are classically irregular. Don't make me get up again. My back can't take. That is a cervical. This is a bone from the cervical spine. So this is a vertebral bone, very small. So that's what's up here at your neck. Okay, and they don't really confine to anything. And they have to, and there's all sorts of different ones. This is relatively small, but one more vertebrae are relatively large. The sacrum that I showed you before is made of a stack of those that are fused together. So you see those illustrations in a second. Bones are my favorite. I have a handout. I will email it to you, and I will also have some hard copies made of it. I forgot to do that this morning. Go figure. The first day my wife left the house in like 10 days from being sick. So finally she's out staying with her mom. After she tested negative this morning, just to make sure. Okay. So it's me and the pooch. It's like he takes up most of the bed anyway. Awful. Here they are, flat bones, sternum. There's really not a lot of good sternum in there. Scapula, we'll show you, it's very interesting, ribs, etc. And the irregular ones, vertebrae and hip. Voila. Okay, and this is all lab stuff. I mean, lecture stuff. Lecture stuff. This is an example of the blood supply. You have blood going up and down, blood going at right angles to that, blood coming in under the edges here, blood everywhere. The beauty of bone is, with that blood supply, if it's broken and you put them together in close proximity and they don't move around a lot, they will heal. Spend a quarter of a century operating on bones, taking care of bones, dealing with fractures and all that stuff. So I have a lot of experience with it, as you could tell. This is what it's meant. This is the outer cortical bone. Deep to it, this is sort of and it's not drawn to scale, this cancellous bone, and here you can see that yellow bone marrow in an adult bone. Okay. Which brings us to what I wanted to share with you today at the very end, and that is, hold on. Go do a message. It's my wife, I gotta tell her. So, this is, it's not, I showed you the femur, but you have to know that there's more than that. There's a series of markings. We're going to get into them. Next time we're going to be doing the axial skeleton. Means we're going to we do the skull first. That's the hardest. But here's what they're like. When there's pulling and tugging, attaching a ligament, a muscle, a tendon, it creates an area on the bone that gets raised. When something sits on the bone, like a blood vessel or a nerve, it gets an indentation. There's certain areas where it just has cartilage. I just want to go over these with you and we're done. So there's three types. Projections, where things pull and tug, the bone enlarges. Surfaces, where it forms joints, they're covered in cartilage. And depressions or openings, that's where things, as growth and development is going on, it's sitting on the bone and it may form an indentation. It may even form a giant opening. And they all have names and you're going to hate it. Okay. So, projections are many. So, some are unique to bone. The lower extremity is peak bone. These are where giant muscles attach. We have a fancy name. They're called trochanter. Very large, blunt, regularly shaped, only on the feet. In between them, there's a line. It's really a bridge called the intertrochanteric line. Trochanter. It's important because when a hip fractures, sometimes it fractures across the neck, it's called transcervical, and other times it fractures here, called intertrochanteric. This one, inevitably you're going to have to put an artificial. That is not deadly, it's just a thing. This one, because the capsule that encloses the joint doesn't go there, the person can die from bleeding out. That's why we classify medicine, science, and classifier. Once you know the classification, it tells you the do's and don'ts, which one's at risk. First thing you learn when you work in a hospital, somebody comes in particularly in a critical situation, like emergency room, take care of what you go on first. Everything else you can kind of pretty up. The thing that's immediately life-threatening, you have to know. Tuberosities, big things attached there. Your patellar tendon, that whole knee jerk thing, creates this big bump. It's called the tibial tuberosity. Big round portion of bone. Crest. So here, it's called the iliac crest. The stand up, your hands on your hip, okay? And that ridge that you find is called the iliac crest. So a lot of times they're underneath the surface. So look at that line, that intertrochanteric line. Tubercles are small. So, for instance, in the humerus, the larger bone of this area, you have greater and lesser tubercles. And there's actually a little indentation. So it is, I have one's not so beat up. Several. The ones in plastic, the real bones get beat up a lot. We bought these 30 years ago from a school that probably had it for 30 years. So they're expensive to get rid of. So these are called tubercles. Greater and lesser tubercle, that's called the intratubercular groove. You hear about someone with a torn biceps tendon goes right in there. It tears and pops out. That's what the tendon came over there. That's there. Condyles are areas that form joints that are covered in cartilage. These are femoral condyles. On every long bone, you have little rough bumps, not with cartilage, called epicondyle. Ligaments attached to it. So every long bone has, on either side, for instance, this is, and these are good to show you. Here is an epicondyle, kind of large, one small over there. And it goes from here to here, and here to here. But there are lateral ligaments. So when you hear someone has a collateral ligament tear, in sport we see it every day, MCL and LCL, they go from epicondyle. Whether it's in your elbow, in your finger, in your toe, in your thumb, doesn't matter. Spines are sharp processes. So when I showed you the actual name where it derives it, this is a thoracic vertebrae. This is the spinous process. When we say spine, it's from these. When you bend over, the doctor's checking you for scoliosis, these kind of pop out a little bit. So you might think you probably had that. It's called the spinous process in the spine. It's not the only spine, you got plenty of spines over there. And again, I know it's beat up and all that good stuff. But there is that's an ischial spine. Over here. That's a notch. It's called the greater sciatic notch. The sciatic nerve. That's the spine of the ischium. So sometimes you can sharpen point. And any of these processes almost any comparison. So those are done. And then the other ones, the ones that are in joints, covered in cartilage, okay, like the head of the femur, that big round circular thing, that's all covered in cartilage. You also have heads on ribs, condyles, that's one that's on the mandible. And so we look at them when they're covered in cartilage, and everything else is an indentation. So we have so many of them. Grooves. We have grooves. Most of them are facial and skull-related structures, probably because there's so many nerves and things like going through that. So you can look inside and see, and even though this is a plastic bone, all those little lines are where blood vessels and nerves sit, and they create little grooves, like structure, which you will see. And the one I showed you before, here in the humerus, like I said, it has a very specific name, the intratubercular groove, because the tendon sitting in there is a bone groove. Effectively, we see that groove when we just look at the bone itself. So a fissure is a slit like opening. The famous fissure of them all is right there. So take a look at the eyes in the orbit. It's sort of like a gash, somewhat triangular. You can see it there. That's called the superior orbital fissure. There's one below it called the inferior orbital fissure. But nothing goes through that. The superior one, nerves go through. Blood vessels. The inferior one still in the cartilage. It's what we call artifactual. So when they process bones, they boil. And then cartilage dissolves and it leaves this opening. There's nothing in there. It's just cartilage. So it's kind of something that's there because the bone. Just to give you an idea. Foramen is a big circular opening mostly. The biggest one of them all is right there. Foramen matter. The brain stem goes through that, and as soon as it exits, like the tip of my finger, it becomes a spine. There's other foramina, that's plural. So here again, they're based on shape. That one's oval, it's called the foramen ovale. Okay? One in here, hard to see. A little round one in here called the rotundum. There's another one that goes sideways, just made out there. That's called the optic ring for the optic. There's lots of parameters in there. Notches, I showed you that one for the notch for the sciatic nerve, that's the famous notch. That's there. Hiatus. So the hiatus is like a passage, like a tongue. So it's got an outside and inside. The most famous one is certainly here, in your ear. That's called the external acoustic hiatus. And it's like a tunnel, and it leads on the inside, but it's hard to see, to the internal acoustic hiatus. So it's like going from Liberty Tubes from going to South Side to 51, and coming across the river. Very busy. I never did tunnels when I map. I grew up in New York City. They went under the bridges. That's a big deal. What? Okay. Sinuses, well, I will see them, although we have one of the bones is typically filled with air or fluid around the nose. And then any of these areas where you see rounded, and you can imagine brain sitting here and here and here, these are called fossa. So it's over time, the lobes of your brain have created this unit. So you have the anterior, middle, posterior, front, Okay. And that concludes today's bone presentation. Have fun. I will send you that list. We will start bones specifically in the skull in earnest. If you want to come up and grab some of the bones, take a look, be my guest.
I resent you that test.
Yeah.
I didn't attach it.
I know you said it. You did. If anybody didn't get that exam in and this Scantron, I brought Scantron. Nobody got it. Test. Here's Scantron. Bring him in tomorrow. Bring him in next week. I know I forgot something. I'm not that smart. Bring him in next week. It's less for me to do. Oh, my aching back. Well, I don't want to look at this. I'm going to be sick.
I emailed you the test. You still want me to do a Scantron and email it to you?
No, I told you sent it already.
All right. Well, thank you.
Did I tell you I got it?
Yes.
Yeah, then I got it. All good. It's not helpful.
No, if this will be okay.
That'd be fine.
Okay.
I'll take that.
Thank you.
Happy. It's just gonna upset me. Might as well look. Can't be that. Trying to be like more than 1-0. I did my job. That's all I can do.